Hello, I'm Dr. Linda Parker, a clinician who has spent years helping older adults make calm, confident decisions about their hearts and blood pressure. Today, I want to talk to you as a straight-talking advocate, not just as a doctor, because there are 3 kinds of blood pressure pills that many people over 50 are still taking out of habit or outdated protocols. Medicines that you should question immediately with your own clinician. I'm not here to alarm you or tell you to throw anything away. I'm here to give you clarity so you can ask the right questions. Avoid side effects that quietly chip away at quality of life, and align your treatment with the best evidence for people in midlife and beyond. If you or someone you love is on blood pressure medication, stay with me to the end. You will walk away with specific questions to bring to your next appointment and a calmer plan for what to do next. First, a quick truth that often gets buried under prescription, refills, and rushed visits. Blood pressure control after 50 is not just about lowering a number. It's about how you lower it, how steadily it's controlled, and how well you function while living your real life. Walking stairs, sleeping through the night, focusing during the day, and enjoying your relationships. A medicine that drops the number quickly but leaves you dizzy, foggy, or at risk for falls is not good blood pressure control. We want steadiness. We want protection for the brain, heart, and kidneys without the daily grind of side effects. That is possible when your plan is individualized and current. The first category of blood pressure pills you should question immediately is short-acting vasodilators, especially immediate-release nifedipine and similar fast-drop drugs. If you've ever taken a pill and felt your face flush, your heart race, and your pressure crash within an hour, you know this sensation. These short-acting agents can create rapid swings, down, then reflexively up, then down again. Those swings are stressful for the cardiovascular system and can trigger pounding headaches, palpitations, and a sense that the room is tilting. In older adults, those quick drops can increase the risk of falls and injuries, and the rebound can actually make the overall pattern of blood pressure more erratic. The original reason these pills were used was the appeal of rapid relief. But what protects you over months and years is smooth, 24-hour control. That's why long-acting options have replaced short-acting ones in modern care. If you look at your bottle and see nifedipine without an extended release marking, or you're using any rapid-acting as-needed blood pressure tablet that you pop when you feel high, bring that to your clinician's attention. There are safer, steadier alternatives that give you even control without the roller coaster. How does this class affect your day? Imagine you take the pill after lunch. 30 minutes later, your shoulders feel heavy, your face is warm, and when you stand, you feel unsteady. By early evening, your body has pushed back, and your blood pressure drifts up again. Now it's harder to settle for sleep. That teeter-totter is exactly what we want to avoid in midlife and beyond. Question any short-acting vasodilator used for daily management. Ask, is there a long-acting calcium channel blocker that would give me smooth, all-day coverage? Can we check my pressure with a 24-hour monitor to see if I'm having dips and surges? That monitor, an ambulatory blood pressure study, often reveals what the office cuff misses. Nighttime lows that leave you groggy in the morning, or evening surges that make you wake with a dull headache. We can only fix what we see. The second category you should question immediately is centrally acting agents used as daily, long-term control. Clonidine tablets, clonidine patches, methyldopa, and sometimes guanfacine when used purely for hypertension. These medicines act in the brain's control centers to reduce the signals that tighten your blood vessels. In emergencies or unique situations, they have a role. But as everyday blood pressure control in people over 50, they can cause fatigue, dry mouth, mental fog, constipation, and, most concerning, problems when you miss a dose. Clonidine is especially known for rebound hypertension. If you run out or forget a dose, your blood pressure can surge higher than before, leaving you with pounding headaches, anxiety, and a trip to urgent care. For older adults who already deal with sleep changes and occasional forgetfulness, a medicine that punishes you for a late pill is a poor teammate. Here's how that looks in real life. You place a clonidine patch on Sunday. By Friday evening, the dose is wearing off, you're busy with family, and you forget to replace it until Saturday afternoon. Saturday morning, you wake with a racing heart and a pressure spike that scares you. That swing is not your body being dramatic. It's the pharmacology of the drug. If a centrally acting agent is the backbone of your plan, ask your clinician whether there is a safer, long-acting alternative with fewer cognitive and withdrawal issues, something that won't cloud your thinking or punish you for a late dose. Many people transition to long-acting calcium channel blockers, thiazide-like diuretics with proven outcome benefits, or ACE inhibitors and ARBs when kidney and heart profiles are appropriate. If you do use clonidine, never stop it abruptly. Tapering must be guided, slow, and paired with another steady agent to take over control. The third category you should question immediately is alpha-1 blockers used as primary blood pressure therapy, such as doxazosin, terazosin, or prazosin, when they are prescribed mainly for your pressure. These medicines can have a place in relieving urinary symptoms from an enlarged prostate. That's a different conversation. But when they are used as first-line blood pressure drugs, especially in older adults, they often cause orthostatic hypotension, meaning your pressure drops when you stand, leaving you dizzy, lightheaded, and vulnerable to falls. They can also lead to fluid retention and, in older studies, were linked to higher rates of heart-related complications when used primarily for hypertension compared with other options. If you take one of these at night for your blood pressure, notice whether you feel woozy when you get up to use the bathroom. If you do, that's a red flag. Ask your clinician, do I still need this for blood pressure? Could we move to a different class for cardiovascular protection and keep this only if it's clearly helping urinary comfort? Clarity matters here. You should not trade fewer bathroom trips for a higher risk of falls and fractures. Now that you know the three categories to question, short-acting vasodilators, centrally acting agents used as daily controllers, and alpha-1 blockers as primary blood pressure pills, let's talk about how to approach your next appointment. You are not walking in to accuse or demand. You are walking in to collaborate. Bring a simple one-page summary. Your current blood pressure pills and doses, when you take them, and how you feel 2 to 3 hours after each dose, and when you stand up. Add 3 or 4 home blood pressure readings taken properly, seated, back supported, feet on the floor, arm at heart level, no talking, and averaged over 2 or 3 measurements. If mornings tend to be low and evenings high, write that down. Patterns matter more than single numbers. Here are the exact questions to ask. First, is any part of my regimen short-acting or likely to cause big swings? If so, can we shift to a once-daily, long-acting option with proven protection for heart, brain, and kidneys? Second, am I taking any centrally acting drug like clonidine or methyldopa each day? If yes, can we plan a slow, safe transition to a steadier alternative so I don't deal with fog, dry mouth, or rebound spikes? Third, I see an alpha blocker on my list. Is it there for urinary comfort or for blood pressure? If it's for pressure, can we replace it with a medication that lowers stroke and heart attack risk more effectively while keeping me steady when I stand? Finally ask, could we do a 24-hour ambulatory monitor once to make sure I'm not having dangerous lows at night or surges in the early morning? That single test has saved many of my patients months of trial and error because it shows what really happens outside the clinic. Let's also identify what usually is safer and more effective in midlife and older adults when used thoughtfully and monitored. Long-acting calcium channel blockers like amlodipine provide smooth 24-hour control and are well tolerated for many. Thiazide-like diuretics such as chlorthalidone or indapamide have strong evidence for stroke prevention when used at appropriate doses and monitored for electrolytes. ACE inhibitors or ARBs help protect the kidneys and heart, especially in diabetes or chronic kidney disease, and they are generally once daily and steady. Beta blockers are not first line for uncomplicated hypertension, but are highly appropriate if you have specific heart conditions like coronary disease or certain rhythm problems. The point isn't to pick your own medicine. It's to make sure your regimen is modern, long-acting, and matched to your body and your risks. Because real life is more than pills, let me give you a calm plan you can start tonight that supports steadier numbers and fewer side effects from whatever you and your clinician choose. Hydrate earlier in the day and taper in the evening. Aim for a 25 to 30-minute walk most days at a conversational pace. The goal is circulation, not athletic heroics. Pair your biggest sodium exposures with movement. If you had a salty lunch, take an afternoon walk and drink water across the next few hours. Practice a 5-minute breathing drill before bed. Inhale for 4, exhale for 6, and let your shoulders soften. These quiet, repeatable habits do more for your numbers than most people realize, and they make your medicines work with your body instead of against it. Let's talk about symptoms that should never be ignored. If you start a new blood pressure pill and feel faint when you stand, if your vision goes gray, if you fall, or if your morning pressure is under 100/60 with dizziness, call your clinician. That is not being dramatic. That is your body reporting that the dose or the timing is not right for you. If you ever have chest pressure, new shortness of breath, weakness on one side, trouble speaking, or a sudden thunderclap headache, seek emergency care. There are side effects we manage in the office and red flags that belong in the emergency department. Knowing the difference is power. A brief word about combinations that deserve attention. If you see both an ACE inhibitor and an ARB on your list at the same time, that duplicate blockade is usually not recommended because it raises the risk of kidney problems and high potassium without clear added benefit. Question that immediately. If you take a diuretic and frequently use over-the-counter pain relievers like ibuprofen or naproxen, be aware that this trio stresses the kidneys. Space them out, use the lowest effective dose of pain relievers for the shortest time, and tell your clinician. This isn't fear, it's adult supervision over a complex body. Stories can make this practical. A 72-year-old gentleman came to me with morning grogginess and afternoon headaches. He was on a short-acting vasodilator twice a day. His home log showed low mornings and high late afternoons. We replaced the short-acting pill with a once-daily long-acting agent, checked a 24-hour monitor, and adjusted the dose to flatten the curve. Within 2 weeks, he stopped feeling yanked around by his medicine. His numbers were similar on paper but steadier across the day, and his energy returned. Another patient, 69, on clonidine tablets for years, had dry mouth, fatigue, and 2 scary episodes after missing doses. We created a slow taper over 6 weeks while starting a safer, long-acting medication. She never experienced a rebound spike because we respected the pharmacology and moved gradually. A third patient, 75, was taking an alpha blocker mainly for blood pressure and stood up at night dizzy, falling once in the bathroom. We shifted his blood pressure control to better studied agents and kept a lower dose alpha blocker only if it clearly improved urinary comfort. The dizziness resolved, and he felt safe walking at night again. If all this feels like a lot, remember that your job isn't to memorize drug classes. Your job is to notice how you feel and to ask the right questions. You deserve blood pressure control that lets you move confidently, think clearly, and sleep steadily. Outdated or poorly chosen pills can steal that from you quietly. Today, is about taking that back. Open your medicine cabinet, list what you take and when, and write down how you feel at your low energy hour of the day and your high stress hour. Bring that note to your clinician and say, "I want smoother, 24-hour control with fewer side effects. Can we review whether any of these fall into the 3 groups Dr. Parker warned about and update my plan accordingly?" Most clinicians will welcome that conversation. It makes their job easier and your life better. Here are the 3 takeaways to keep in your pocket. 1. Question any short-acting rapid blood pressure pills used as daily control. Steadiness beats speed, especially after 50. 2. Question centrally acting medicines like clonidine when they are your everyday controller. They can fog thinking and cause rebound surges if a dose is missed, so transitions must be planned and gradual. 3. Question alpha blockers used primarily for blood pressure rather than urinary comfort. They can drop your pressure when you stand and raise your fall risk, which is the opposite of healthy aging. Do not stop or change anything on your own. Schedule a review. Ask for a 24-hour blood pressure monitor if your readings are inconsistent or your symptoms don't match the office number. Ask about once daily long-acting options with proven outcome benefits, and support your numbers with quiet, durable habits, earlier hydration, a daily walk, calmer evenings, and consistent sleep. This is how you protect your brain, heart, and kidneys and still feel like yourself. Let me leave you with one sentence to carry into your next visit. Better blood pressure care after 50 is calm, steady, and individualized. You don't need a faster pill, you need a smarter plan. If this conversation gave you clarity, reflect for a moment on which question you'll ask first. Share this with someone who needs a safer, steadier path. And if you want more clear, compassionate guidance for healthy aging, subscribe and stay with me. I'm Dr. Linda Parker, and I'm on your side.